I'm Rohit Loomba, Director of NAFLD Research Center at UC San Diego. And for last several years, we've been interested in developing a new imaging-based biomarker for assessment of NASH and NASH-related fibrosis. This particular paper that Rajiv asked me to write for Journal of Hepatology is focused on serum and imaging-based biomarkers of non-alcoholic steatohepatitis and NASH-related fibrosis. Dr. Chalasani, my colleague, is working on the serum-based biomarkers, and I focused on the imaging-based biomarkers. We've spent several years understanding why imaging tests work for assessment and which ones work better than the others. And this review focused on 3 clinical questions. Patient comes to my clinic and I'm trying to answer, does my patient has non-alcoholic fatty liver disease? To assess that, what type of test do I need? What is the value of each individual test? So you have a CT scan, you have an ultrasound, you have a CAP, control attenuation parameter on FibroScan, or you are doing an MRI, PDFF, or MR spectroscopy. When to use these tests and what is the value of the result it comes and how you can interpret those results. So that answers one question, does my patient has NAFLD? Second question, does my patient have NASH-related fibrosis? And we try to assess that as well in the review and say which of these modalities are better and what's the hierarchy of these modalities and why. And then we move on to advanced fibrosis. Why is that important? Because I think it's prognostic. So patients with stage 3 and stage 4 fibrosis related to NAFLD are at increased risk of dying from liver disease. And as a hepatologist, I would like to identify that and tell to my patient that you may have that, that's why I'm following you, and I want to reverse or stop the progression of your disease. Can we do that without doing a liver biopsy? And in this review, I have shown as to how I think about these imaging modalities. When do I use MRE? When do I use FibroScan? And how to interpret those results. What is the diagnostic accuracy of MRE versus shear wave elastography on ultrasound versus VCTE? And is it different, and in what group of patients? So one thing to consider, especially introduced in this review, is as the body mass index increases, so you go from a normal BMI to overweight to obese to morbid obesity, the ultrasound-based tests do not perform as well, but they perform very well in individuals who are lean or just overweight and not obese. So we could potentially utilize a plan in future which would be use some sort of a clinical prediction rule early on, such as FIB4, rule out a group of patients who don't need further assessment. Next, you may introduce a VCT, FibroScan, or ultrasound-based assessment, and that could be utilized in a majority of patients. And then only a select minority who are still need further assessment may get into MR elastography. Briefly, then I touch upon how we utilize these tests in the setting of treatment trial and what are the quantitative decrease in these modalities that may have some clinical significance in future. In future, we're going to have a combined panel where serum-based test will be plugged in with an imaging-based test to detect NASH-related fibrosis. That's where the future is going to be. And the future will rely on ultrasound-based assessment first, whether it's a FibroScan or shear wave elastography of some kind, followed by a more advanced technique. Future of clinical trials will depend on MR-based assessment because you want to be more precise and accurate. And that's where I think we would see the main progress in the next 5 years.